Good afternoon, everyone. Thank you so much for joining us today. Welcome to our SBCMS webinar presentation, Monkeypox, Updates on Symptoms, Spread, Treatment, and Vaccines. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. Our partners today are from San Bernardino County Department of Public Health and Choice Medical Group, who continue to work with us to provide educational sessions and discussions for providers as well as community advocates. I'm going to introduce our three speakers right now, and then following their presentations, we'll take your questions and answers at the end. So as you're listening to our presenters, please feel free to enter your questions into the chat feature on your Zoom dashboard, or you can click the raise your hand feature, and that will allow us some interaction as well. And of course, if you're not speaking, we greatly appreciate you keeping your sound on mute. First, we'd like to welcome Ashwini Mallad, MD, Infectious Disease Physician Specialist with Choice Medical Group in the High Desert. She graduated from University of Massachusetts in 2019, and currently she's active in both inpatient and outpatient infectious disease treatment in her practice. In our outpatient clinic, as part of Choice Medical Group, she treats regular infectious disease cases such as wound infections, bone and joint infections, follow-up from inpatient consults, and she also treats HIV, hepatitis C, and sexually transmitted diseases. Dr. Mallad's inpatient work has her at 3 high desert hospitals: Desert Valley Medical Center, Victor Valley Global Medical Center, and Providence St. Mary Medical Center. She's part of several committees, including the COVID Task Force, Antibiotic Stewardship, Chief of Pharmacy and Therapeutics Committee at Desert Valley, and the peer review committee, as well as many others. Welcome, Dr. Mallad. Next, we'd like to introduce our good partner, Michael Sequeira, MD, Fellow of the American College of Emergency Physicians, who's our Public Health Officer for San Bernardino County Department of Public Health. Dr. Sequeira received a Bachelor of Arts in Zoology from Pomona College in Claremont and graduated with his medical doctorate in the top 10% of his class from UC San Diego School of Medicine. He completed his residency in internal medicine and emergency medicine at the University of Oregon Health Sciences Center in Portland, Oregon. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 hospital emergency departments. He is past president of SBCMS in 2016-17, yay! And he's a member of the steering committee and the founding members of the Inland Empire Opioid Crisis Coalition. He also serves as National Risk Director for Vituity Healthcare. Welcome to you, Dr. Sequeira. And we also welcome, thank you. We also welcome Sharon Wang, DO, MSHPE, who is San Bernardino's Deputy Health Officer as of this June, I guess it was, May or June. Dr. Wang was previously the Chief of Infectious Disease at Arrowhead Regional Medical Center, ARMC. She graduated from UC Berkeley with her bachelor's degree, completed training in dietetics at Yale University, and finished medical school at Western University of Health Sciences in Pomona, where she graduated number 5 in her class. At the same time, completing her master's degree in health education. After receiving her DO degree, she completed an internal medicine residency and infectious diseases fellowship at UC Davis. She's dually board certified in internal medicine and infectious diseases. Dr. Wang is a widely respected specialist in infectious diseases and helped to found and maintain the antibiotic registry at ARMC. She was a key infectious diseases consultant for ARMC's COVID response and treatment program during the pandemic. And one reason I admire Dr. Wang so much, she's a foodie and loves to travel with her beautiful family. So welcome, Dr. Wang. At this time, we are going to start off with an introduction and overview by Dr. Sequeira, and then we'll have our presentation. So Dr. Sequeira, we will turn it over to you.
Oh, thanks, Allison. And I wanted to thank again the Medical Society for sponsoring this, and Dr. Mallad for stepping up and being part of the intellectual trust that to be able to present this. We're doing a lot of good things, and the Department of Public Health has really beefed up during the COVID pandemic, and in the course of that, we happened to come upon another epidemic, hopefully, and it won't be a pandemic. But so we, this is something that we've been able to really respond to quickly, and with regard to education of our providers as well as our populations at risk, and to get information and dissemination of our vaccinations and therapeutic agents, including Sequeira. So it's a huge part of this is educating and keeping up to date all of our providers, and that's hopefully the purpose that will be easily achieved with this symposium or webinar. I'm going to turn it over at this point. There's a lot to this, and there's been a lot of work. I know I'm so happy that Dr. Wang is now my partner in being a health officer. She's been a tremendous resource, and we're just getting to know Dr. Mallad, and we hope to see a lot more of her as well, and within the society and within the infectious disease public health arena. So with that, I'm going to turn the initial part of this presentation over to Dr. Mallad.
Thank you. Let me. Okay, are the slides visible, right?
Yes, yes, they are.
Okay, so
looks good.
Okay, perfect. So, so let's start the presentation. So I'll start with the current situation. As of this month, globally, there are 62,000 reported cases, and in US alone, there are 23,000 cases. California stands top in the list when you see the distribution of cases around different states, accounting for almost 4,600 cases. More than 50% of cases are reported in LA and SF area. There is one death reported, 173 hospitalization, and there are 8 cases under age of 16. San Bernardino has 95 probable to confirmed cases and 0 cases for ages less than 18. Riverside, there are reported cases of 278. When you look at on the right side of the graph, like gender identity and sexual orientation, where the cases are most common, and we see mostly it's reported in male, and the highest we see in gay or same gender people for almost 82%, and the other people are like bisexual, heterosexual, have also cases reported, and they're followed by which are transgender male. Again, it's divided into like gay, bisexual, and heterosexual. Now looking at the overall trend of the cases reported from initially when it started, that is May 17, 2022. The good news is the overall trend is coming down. I think that's what we can take it from this slide. Now looking at cases in terms of race and ethnicity by week. If you can see on the left side of your slide, initially it was mostly reported in white ethnicity in May 2022, but as the time progressed, the cases reported are more in minority community like Hispanic and Black. Hence, the proper distribution of vaccines and medications are important. How does the virus transmit? The virus does not discriminate against any individual's sexual orientation, race, color, gender, or age. Most cases due to prolonged close physical contacts. It's unlikely to get Mpox from casual conversation with infected or going to a grocery store. Direct contact with body fluids or lesion materials can increase your risk of getting the infection, such as skin-to-skin contact, intimate contact, prolonged face-to-face contact, sharing of fomites during intimate activities, or contact with infected animals like activities such as hunting, trapping, processing of infected animals and body fluids. This slide briefly shows what is like spreadability of the individual infection. If you look at measles, one person can give it to almost 12 to 18 new cases. In COVID, Omicron BA.5, 7 new cases can occur from one infected case. In chickenpox, 9 to 10 cases. But when you look at monkeypox, the overall spreadability is quite low. From one infected cases, there could be 2 new cases. This slide is mostly for healthcare providers to look. The CDC has provided the case definition for Mpox. So what is suspect case? When you see a new characteristic rash, which meets epidemiological criteria or has high clinical suspicion. I will talk about epidemiological criteria in next slide. The next definition is probable case, where no suspicion for other orthopox virus exposure and has positive lab evidence by PCR, electron microscopy, or antibody test. The next is confirmed case, presence of monkeypox virus DNA by PCR testing or next-gen sequencing or isolation of monkeypox via culture. So what are the epidemiological criteria CDC is talking about? So within 21 days of illness onset, if the patient reports having contact with a person or people with similar appearing rash or who have received a diagnosis of confirmed or probable monkeypox, or had close or intimate in-person contact with individuals in social network experiencing monkeypox activity. This includes men who have sex with men, who meet partners through online website, digital application, or social events, or who traveled outside the country with confirmed cases of monkeypox or where monkeypox virus is endemic, or had contact with dead or live wild animals or exotic pet that is an African endemic species or used a product derived from such animals, such as meat, creams, lotions, powders. What is the exclusion criteria? A case may be excluded as a suspect, probable, or confirmed if an alternative diagnosis can fully explain the illness, or an individual with symptoms consistent with monkeypox does not develop a rash within 5 days of illness onset, or a case where high quality specimens do not demonstrate the presence of orthopox virus or antibodies to orthopox virus. This shows the most common signs and symptoms reported from all the cases since May. So the most common symptoms is rash, which is accounted for almost like 90 to 100%. And more than 50% cases have genital rash. Then followed by fever, malaise, chills, headache, pruritus, enlarged lymph nodes, myalgia. There could be other atypical symptoms like rectal pain, tenesmus, proctitis. Again, it comes under rectal pain, conjunctivitis, eye pain. In severe cases, there could be vision loss, low blood pressure, and altered mental status. Between these two pictures, if you have to identify which one is monkeypox virus versus molluscum contagiosum, this is just to show that monkeypox virus has a very characteristic rash, and you should be able to differentiate with other kind of rash. In monkeypox rash, the rash is firm, well circumscribed, deep-seated umbilical rash, and this right one is flat, which is more like a molluscum contagiosum. Let's look into clinical course. So there are two types of presentation. One is classic presentation, which is usually occurs in the endemic countries like Africa, where the incubation period is 5 to 13 days on average. And they have prodrome symptoms like fever, malaise, headache, weakness, lymphadenopathy that may be generalized or localized to several areas. The rash appears shortly after the prodrome start. Typically, lesions develop simultaneously, evolve together on any given part of the body. The rash goes into like 4 different stages: macular, papular, vesicular to pustular, before scabbing over and resolving. Wells, as I earlier said, wells are from deep-seated with umbilication, and it is painful. When disseminated, tends to be centrifugal, more in like arms, legs, hands, feet, and it can also involve palms and soles. The illness typically lasts 2 to 4 weeks. And this is the picture from the classic case where you see there are a lot of lesions in the endemic monkeypox. However, in 2022, these lesions are very localized or scattered or very few in number. Rash often starts in mucosal areas like genital, perianal, oral, or may not develop simultaneously in all body areas. The other, like you should keep an eye on, like patient may complain like balanitis or urethritis, especially on the penis, proctitis, anorectal pain, tenesmus, rectal bleeding, or you can also see rash in the oral area, which is complicated by tonsillar swelling, abscess, or dysphagia. And in this cases, prodrome symptoms can be absent or follow rash onset. These are some of the pictures recently published in New England Medical Journal, and it is just to let you recognize what kind of rashes it may present. And these are like oral rashes. These are some penile lesions you could see in patients. And then these are perianal, anal and rectal lesions you can see around the anal. So the most important question is how to test them. And there are commercial labs available now through Quest, LabCorp, and these are the test code for your reference. And currently, BPH lab only is testing for only high priority cases, such as cluster outbreak or pediatric cases or severe illness, hospitalization, or where no commercial lab is available. Sample collection. This has a specific method, hence I'll go a little bit in detail. Wear PPE to protect yourself. Then you have to use a sterile synthetic swab. Do not use any cotton swab. You have to like apply a very firm pressure with rigorous swabbing to get as much DNA as much as possible. You do not need to deroof the lesion. Okay. You collect 2 swabs from each lesions. Okay. And if you find crust, even that can have high PCR load. So you can even send a sample of crust, but sometimes some lab may not test it. So hence double check with the lab if they test it from crust or not. For crust, use forceps or some blunt tipped sterile instrument to remove the crust. And then you can put small amount of crust in the sterile container and send it to the lab. This is just for information from CDC website about how to collect, ship the specimen. Okay. Coming to management, most patients with intact immune system do well with only supportive care and pain control. Antiviral treatments are available for people who are at high risk of severe illness. Like for example, severe immunocompromised due to conditions such as advanced HIV, leukemia, lymphoma, or malignancy, organ transplant, etc. Or the patient is pregnant or breastfeeding, or pediatric population, especially patients younger than 8-year-old, and people with condition affecting their skin integrity. The treatment currently distributed is tecovirimat. Again, it is actually FDA approved for smallpox, but we have expanded access for monkeypox use. And currently you can get this medication through EA, Investigation New Drug Protocol, through Public Health Department and CDC. So it's available in IV and PO form, 600 milligram BID for 14 days, usually given with 25 gram of fat, available from National Strategic Stockpile. it reduces the duration of illness and viral shedding. Currently, studies are going on to really tell how much does it make difference in monkeypox cases. This is the algorithm to show who are the appropriate people where we should be using TPOXX. So first, we have to see if the patient is tested positive for monkeypox. If yes, then does the patient have severe disease as the following, like one of the criteria, like either hospitalization, encephalitis, hemorrhagic disease, confluent lesions, sepsis, or painful mucosal lesions like in genital area, eye, mouth. And yes, then you can get them TPOXX, but again, you have to call particular number given below at CDC, or you can email for DPH San Bernardino County to get that. And also, like immunocompromised patient, if age less than 8, pregnant, breastfeeding women, and severe skin disease can also get this medication. If they don't meet this criteria, then basically it's isolation, supportive care, and monitor for complications. Through the CDPH website, there are more helpful tips to how to care for the skin rash, lesions. So I have attached the link here for your reference. And also some cases may need like multi-subspecialty when you're taking care of the patient, such as for like eye involvement, you might need ophthalmology, for rectal pain, lesions, you may need GI on board. So sometimes you have to think about getting subspecialty on board to take care of these patients, especially in severe cases. I want to mention specifically about HIV patients. And recently, the severe cases are being reported in HIV patients. And sometimes new HIV infection are being diagnosed with monkeypox. So hence, if anytime you see monkeypox case, I would suggest testing for HIV. And also other STD infection can co-present or might present a confusing picture like secondary syphilis, herpes, etc. People with advanced HIV or who are not virologically suppressed are increased risk of severe disease. They may have like diffuse and coalescing lesions. They may develop lymphadenopathy. Even one case, I recently attended CDC IDSA on-call meeting where they recently reported one patient with septic shock with monkeypox. And sometimes it could be secondary due to co-infection from bacteria, which worsens the condition. And there are also cases reported with encephalitis, myocarditis. Fatalities have been reported in patients who are not virologically suppressed, and increased risk of transmission is noted in HIV patients. For those who need treatment, no major interaction with antiretroviral medication is noted. Hence, if they're already taking their ART medication, do not need to stop, just continue in addition to giving TPOXX. And if the patient is on long-acting cabotegravir or rilpivirine, then we would recommend delaying starting this combination while giving TPOXX. For other patients, like post-exposure prophylaxis are available, especially for people who are exposed to monkeypox. Vaccination with Juniors is considered safe, and Dr. Wang will give us further details in next few slides. Thank you. Now I'll pass on to Dr. Wang.
Thank you. So I'll be discussing more the county effort and how do we disseminate resources to the acute care hospital settings and also clinic setting. Thank you, Dr. Mallad, for the overview. Next. So what can public health do for you during this current outbreak? If you have a suspected case where you are swabbing the patient or you're considering starting patient on teicobirimab empirically because the patient meets the case definition of lesions that look very classic, patient had a very positive contact with a known case, involve your infection control department. they can get a hold of us, or you can contact us directly. What public health will do is we will assist with contact tracing and offer post-exposure prophylactic vaccine. That's very important because it's time sensitive, and I'll go more into vaccines. We can also assist with workplace notification if there is a significant concern at work, whether this is, whether there's monitoring that needs to be done. With COVID, we had relied on our community health partner or our community business partner to help us do that. But it's time for public health to take back contact tracing and assistance in terms of notifying the potential exposed. Let us do that uncomfortable conversation with the employer. And the very important part of the contact tracing is really to break that infectious cycle. The faster we can stop that cycle, the faster we can contain an outbreak. Next slide. Okay, so when we hear about a potentially exposed, and again, this is like any other post-exposure, first is to determine the risk. Is this interaction considered a high risk where you would, the risk of you getting an infection is high. So that's the highest exposed. So if there is broken skin with the infected contact, so the prolonged close physical contact, that's the most likely way that you will contract Mpox. So that is considered the highest exposure. And both we do contact tracing, we do determination of the risk both in the healthcare setting and in the non-healthcare setting. In the healthcare setting, we determine whether the healthcare worker was wearing the proper PPE or not, because that will also determine the risk of you catching the disease or not in the healthcare setting. A low risk exposure is someone who goes to the grocery store, talks to someone who's infected with Mpox, a brief interaction. So you can see public health and CDC offers guidance in terms of what is considered a high exposure risk. Next. Sorry. So the most important things besides offering in the vaccine is symptom monitoring. Listen to your body. If you are exposed to someone with Mpox for the next 21 days, pay attention to your own physical health. Look for any signs of symptoms that potentially could be an early sign of Mpox. However, unlike COVID, there is no need to quarantine or be isolated or change the way you go about your daily business unless you develop any of the symptoms that potentially could be Mpox: fevers, chills, swollen lymph nodes, new skin rash. Then you need to stay isolated and be evaluated. Next. If symptoms occur, if any of the prodrome occur, you have 5 days to work with your clinician to figure out what is causing the infection or your symptoms. If you have a rash, isolate and be evaluated. If Mpox is ruled out, then you can come up isolation. So that 5-day gives you time to figure out. Maybe your fever is due to a dental abscess that you all of a sudden realize you have cavities. So it kind of gives you that room to work with your provider. Next. If you do come in contact, so Genius vaccine is available to you. The highest priority is for those who have been exposed. So public health will work with you, your hospitals, if you have the vaccines. This is the top priority because you have 14 days after the last exposure to the case to be vaccinated. Or they have expanded post-exposure. If you know your patient went to an event where there's close physical contact and there are known cases of Mpox, or Mpox is likely to be present at that event and there's a lot of physical contacts, then you also qualify for post-exposure prophylaxis with the Jynneos vaccine. As for pre-exposure prophylaxis, both in the work setting, so laboratory workers who are actually doing the diagnostic testing, so they're actually handling the specimen and running the test. Pre-exposure prophylaxis is recommended. Researchers that are handling infected animals, their specimens. Right now, unlike the COVID vaccine, it is not recommended for healthcare workers, except the ones that I mentioned above. And the reason is because it's not a highly contagious disease. We have no shortage of PPEs to provide for the frontline workers. And that's why CDC is not recommending universal vaccinating of the frontline. This potentially could change. Again, everything is fluid and recommendations, criteria could change depending on when we get more data. And yes, it is mandatory to report Mpox under Title 17. So if you do have a case, you need to report it to public health within 1 business day. Next slide, please. For the non-occupational PrEP, so pre-exposure prophylaxis, because there's still I wouldn't say shortage, so the vaccine is still not widely available. CDC and CDPH put together a priority guidance for clinicians, for hospitals, for clinics to prioritize who should be vaccinated. And this is based on the epidemiologic study of the current outbreak who are involved with, which patient populations are more likely to have the disease. So the tier 1 priority group are those who gay, bisexual, cisgender loving with 1 risk factor, and that risk factor being recent STIs, were diagnosed with syphilis, gonorrhea in the last 3 months, or they have risky sexual practices, or will be attending large events. Survival transactional sex workers, they're the #1 priority. And it goes to tier 2, similar priority, but it expands to include STIs within the last year. Also, patients who qualify for HIV PrEP, patients living with HIV and at risk for Mpox, these are all considered the priority groups. Other priority groups to consider are those who frequent congregate settings, substance treatment center, homeless shelter, detention center, correctional facilities. So if you service this population, reach out to us. We will get you the vaccines to help you vaccinate. I always say, don't wait, vaccinate. So don't let an at-risk patient go without offering them the vaccine or give them the pathway to get vaccinated. Next slide. And for prevention, so the vaccine, it's the Jynneos vaccine. It's a live attenuated non-replicating orthopox virus. It's a 2-shot regimen. Sounds familiar, right? 28 days apart. You are going to get a local reaction because the primary route of vaccine is intradermal. So these are single dose vial for subcutaneous injection, but they've done immunogenic studies that show if we give the vaccine intradermally, like we do a PPD placement, then we can actually use 1/5 of the dose. So overnight, when FDA came up with this recommendation, with this approval, our vaccine supply increased 5-fold or up to 5-fold. So this is great news. One way to get on top of an outbreak is prevention, offering prevention to the at-risk individuals. So intradermal is the way to go. It's FDA approved for adults 18 and up. For pediatric is still under EUA. So the vaccine is approved for, is under EUA for pediatric post-exposure prophylaxis. So if a kid is exposed, we want to vaccinate the kid. We want to vaccinate the kid right away. And the reason is when the pediatric population, if they do have Mpox, they are at high risk for progression to severe disease. So kids are our priority as well. We are currently in the phase 4 allocation from the CDPH, and we have allocated the vaccines over 85% of our supply to our local partner in our community. I see Dr. Roloff's question. I will address that shortly. Next slide, please. The vaccine for the intradermal is the route we recommend, but for pediatric cases and also individuals who are likely to scar to form keloids, we also recommend the sub-Q injection. Next slide. How do you give the vaccine? How do you recommend your at-risk individual to get the vaccine? There are 2 ways. You can ask us for the vaccine, we'll send them to you. The other way is please visit our website. You just type in San Bernardino County monkeypox. It will take you to our website. We have information for the public, for the providers, and ways for you to request vaccine. If you have a patient or patient's family who you think qualifies for pre-exposure prophylaxis, they can go onto our website and click on the vaccine interest form. There'll be questionnaires, confidential questionnaires for your patients to fill out. And based on our internal metric, the prioritization, one of our team member will call you or send you an email within 24 to 48 hours to schedule an appointment. Next slide. Going back to infection prevention, the healthcare setting isolation guidance, there's no difference in terms of how we isolate them in the acute care setting compared to COVID. This is not an aerosol generating disease, but out of abundance of caution, OSHA felt that a 95, and when you're caring for someone with Mpox, a 95 is still recommended for the potential possibility that if you cough, somehow you can aerosolize the drop, aerosolize their secretions. And that's why. So single room with dedicated bathroom is possible. The patient, all the lesions should be covered, mask if possible when they're interacting with other healthcare personnel. And this is important for both nursing and EVS to never shake the bedding or dust during handling of any of the soil laundry. Any procedures that will potentially aerosolize secretions should be done in a negative pressure room, but otherwise the patient does not need to be placed in a negative pressure room. There's some waste management consideration for the acute care setting and also for home isolation. And then it's just standard EPA registration. Next slide. And CDC also, so one of the hardest part about this disease, like Dr. Mallad pointed out, it's very self-limiting, but one of the hardest part is staying isolated. The lesions usually will take 2 to 4 weeks, sometimes longer if you have an immunosuppressed host. So they are to be in isolation until the lesions healed over. And a lot of time they need a lot of support. So CDC has some very helpful guidance on there for you to refer to. Next slide. Okay, so we have these slides both in Spanish and English. If you like, we can send them to you. You can print them out and pass it out or post it in your exam room, give it to patients to give it to them. We also have a QR code that will take you directly to the patient link for to how to secure an appointment. Next slide. Our vaccine sites, we have clinic sites strategically placed everywhere in our county. The vaccine appointments are not full. We can accommodate more at-risk individuals, so please help us get the words out. If you think you meet the tier criteria to to hurry up and fill out the information so we can schedule you an appointment. We are doing second doses as well. Please help us reach your at-risk patients. Next slide. For healthcare, so a couple of things I do want to address is, if your clinic or your hospital want to provide vaccines, just go to our website and you can put in the vaccine request form. However many doses you want 20 doses, 20 vials, which will give you 200 doses, or you want 50 vials, put in a number that you can work with. Our team will reach out to your pharmacy team to arrange for delivery. If you have an HIV PrEP clinic, you see HIV patients, you go to your psychiatrist lesson and go into substance treatment center. If you want to provide the vaccine service for your patients, please ask us for the vaccine. The other part where you can do is for your clinic or for your clinics or for your hospitals that want tecovirimat, the TPOXX antiviral for your at-risk patients. You can also go to our website to ask for a request, but you need to fill out an FDA IRB form for your organization, and that will cover the clinic. So we can send you antiviral medications, we can send you vaccines, you can send us patients to get scheduled for vaccine, and we have the resources to support you. I see a question about LA County. So the vaccine appointments that are within public health, as long as you're affiliated with San Bernardino County, you go to school here, you work in San Bernardino County, you recreate in San Bernardino County frequently, we will support you with a clinic appointment. The vaccines, so CDPH keeps a close tab on vaccines for providers who want the vaccines. If LA County does reach out to us to ask for vaccine supplies, that's something that can be shared. But that decision, that conversation will happen above, it's above my pay grade. But we have been sharing our vaccine supply with Riverside County. So the sharing of county supply can happen. I see a question from Dr. Roloff. These genital lesions look so much like syphilis, and that is absolutely right. The medical board notice, so medical board sent out a medical board notice last week that asked all clinicians, if you are screening someone for monkeypox vaccine eligibility, please also screen them for all the STDs, HIV, HIV PrEP if they're a candidate. Test all person, everybody who's being evaluated for Mpox for other STDs. They recommend checking for HIV, checking for syphilis, checking for 3-site testing for chlamydia and gonorrhea as appropriate. And the reason for this is the current outbreak. They looked at 2,000 Mpox cases. 38% of the 2,000 cases were co-infected with HIV. 41% of this cohort of patients with Mpox had one or more bacterial STIs in the preceding year. Even though this is not a sexually transmitted infection, and anybody can get it, but the current outbreaks does look like it is involved, prolonged close physical contact is a big route. So please keep the other common STIs in mind. For me, I feel like the Mpox is still the zebra. We have 95 cases in San Bernardino County since we started the outbreak a couple months ago. This month alone, we have over 300 syphilis cases that our case managers are working on. So look for the common things being common. probably it may be the syphilis that you're looking at, not the Mpox. So screen for both. That's all I have. If you guys have any questions about my part or Dr. Mallad, I'm happy to try to answer your questions or comments or concerns. Thank you very much.
Wonderful. Dr. Sequeira, did you want to add anything?
He might be on another meeting.
He might have jumped on another meeting. Okay, fantastic. Well, then we can go ahead and start some questions and answers, or there are a couple in the chat, and you've gotten to some of these actually, Dr. Wang and Dr. Mallad, but Soteria, what are you seeing anything new that we haven't already covered here?
No, Dr. Wang answered all the questions.
Fantastic. Okay, well, does anyone want to raise their hand and ask a question? There must be some things you might like to know about this, since we have the experts here. No more questions, huh?
And if your clinic would like vaccines or medications or in service on how to handle, how to treat syphilis, I'm happy to come to an in-service for your clinical setting.
That's really, really great of you. This is all such wonderfully organized information, not only from both of you, but this is great that this is all on the public health website as resource for providers and the public. And it's just really comprehensive. So I think it's always a good place for people to start and look there, and then kind of navigate from there. And then, you can always contact one of us too at the Medical Society if you need help getting in touch with Dr. Wang or Dr. Mallad to figure out what your next steps are. But well, that was wonderful. Thank you both so much. We sure appreciate that.
Follow us on Twitter, Facebook, and Instagram.
Yeah, absolutely. Follow Department of Public Health, follow Choice Medical Group, and also I'll put in a plug for following San Bernardino County Medical Society. We've got all of the things we post, and we do share and amplify from our partners that we just mentioned on our Facebook and Instagram pages. So and Dr. Wang has put in the Twitter account there, so as well as an email for contact and follow up there. And we will, to both of you, doctors, are you going to be comfortable? Can we share these slides with our participants? Okay. Yeah, is that also Dr. Wang, or are you good with that?
Yeah, there's a couple more slides I'm gonna add on there. So I'll do that and send it to you. Just our
Sure.
links to our website.
That's wonderful. Well, thank you both. So by Friday, we'll get that sent out to everyone, as well as attached to that the recording of this presentation, so you can share it with others or watch parts of it later if you would like. And again, be sure to check out SBCMS website as well, Facebook page, San Bernardino County Medical Society on Facebook, Instagram, LinkedIn, Twitter, and you have all the DPH information there as well. So we want to thank Department of Public Health and Choice Medical Group and Dr. Ashwini Mallad, Dr. Sharon Wang, and Dr. Michael Sequeira for being such wonderful steadfast partners with us in educating everyone on these up-to-date issues. I do want to put in a really quick reminder to everyone. We have a blood drive tomorrow at SBCMS starting at, what is it, Saturday, 1:30 or 1:45? Yeah, 1:30.
Yeah, 1:30.
1:30, and that's at San Bernardino County Medical Society in Redlands, 1859 West Redlands Boulevard. So we encourage you. We're still have a few slots open. There's a tremendous shortage of blood in our county in Southern California and beyond, as you know. So trauma procedures depend on this blood, and many of your patients are going to be needing this blood. So we really, really are pleading with you. Please sign up. And you can just go to sbcms.org/events and click on the link, and you'll find the way to sign up for your time slot tomorrow. All right. Well, thank you again, everyone, for our wonderful presentation, to our presenters. And thank you all for joining us today, folks. And we will see you again soon. We'll stay tuned for our next upcoming webinars. We've got something coming up on long COVID and others in our COVID equity series, thanks to Department of Public Health grant project. So, all right, everyone, have a great week. Thank you so much. And we will see you all soon. Bye-bye.